He's behind the big gray box. Hi, I'm Michael Schmidt, and you're with us at ICAAC Live. You can follow us on Twitter at #ICAAC. ICAAC stands for the Interscience Conference on Chemotherapy and Antimicrobial Agents, and today we have with us two of the presenters who have been selected from the program chairs to chat with us. And so we're very fortunate to have Kelly Daniels from the University of Texas at Austin, and Philip Chung from Albert Einstein. And they're going to share with us some really exciting results on the rise of C. diff infections in the United States hospitals. Kelly's going to talk with us about that. And Dr. Chung is going to talk with us about comparing the effectiveness of two oral vancomycin regimes for the treatment of C. diff infections. So Kelly, we're going to go to you first because this is the big one. C. diff infections are on the rise, and inquiring minds want to know why. So hopefully you'll be able to share with us the story.
Sure, absolutely. So just to give you some background on some prior epidemiological studies, there were some large studies that demonstrated an increase in CDI, or Clostridium difficile infections, in hospitals in the United States, Europe, and Canada in the 1990s through the early 2000s. But more recent studies are limited. And actually last year, the Agency for Healthcare Research and Quality published a report documenting the rise in Clostridium difficile infections in hospitals in the United States. So the goal of our research was to build upon older prior epidemiological studies and supplement the HRQ report by looking at trends in Clostridium difficile incidence, mortality, and length of stay among hospitalized adults using a second national database. So what we did was use the National Hospital Discharge Surveys, which are surveys conducted by the Centers for Disease Control and Prevention, and we tracked trends in Clostridium difficile infections among adults. And the big findings from our study was that we found an approximate doubling of Clostridium difficile incidence from 2001 to 2010.
So how do they measure that? Do they inquire with the patients, or do they look for a clinical readout on a particular chart? How do they get to that question?
Sure. So the CDC, the way they survey patients is they have a sample of about 500 hospitals, and they use administrative data. So in this case, the International Classification of Diseases, 9th revision codes. So unfortunately, we can't confirm CDI diagnosis with toxin assays or other laboratory methods. It's simply based on administrative data.
Well, that's okay.
Yeah.
And what did you learn?
Yeah. So what we learned, again, we are supplementing other studies that are showing that Clostridium difficile is still a major problem in hospitals, and that it's still on the rise. And if you actually look at the trends, we did see somewhat of a leveling off of incidents from 2008 to 2010, which is a signal that things might be starting to improve. However, we've yet to still see a decline in Clostridium difficile infections in hospitals.
Do you think that was a consequence of maybe an enhanced hygiene campaign because of the 2009 pandemic of influenza?
Possibly, yes. So, infection control, especially hand hygiene, is definitely something that can prevent not only Clostridium difficile infections, but other healthcare-associated infections, influenza, definitely. So it's possible that the bigger push for preventative efforts in recent years have caused a reduction in these infections.
Tremendous. It sounds like a lot of work.
It is, but it's fun work.
So if any of you out in the Twitterverse have questions, feel free to ask the question at #ICAAC, and we'll be able to answer it live on the air, so to speak. And we have a question from our live audience. Please.
Thank you, Michael. Michael Smith from MedPage. Dr. Daniels, you said administrative data, but what sort of administrative data? Is coding for antibiotic use or coding for the actual infection itself, or what?
Yes, so the code that is used is for the actual infection itself. So there's a code 008.45 that is specific for Clostridium difficile infections, and that's the only code for Clostridium difficile infection.
And presumably this would have arisen because of actual disease as opposed to simple colonization.
Yes. Yes.
So these are, what you're measuring are people who are sick with C. diff in hospitals.
That's correct. That's correct.
Thank you.
So this even drives home the significance of your research even more so, because as the question from the audience suggests, we're actually measuring a doubling in disease
Correct.
in 10 years. So this is sort of headline news.
Yes. It's kind of scary, actually.
It's kind of scary because, as most people in the clinical world appreciate, is that should you get C. diff, you're looking at unformed bowel movements for a very long period of time until you hopefully clear it, or people like Dr. Chung come up with a new way of addressing that issue. So it's a poor man's segue into Dr. Chung's research. And then we'll have a discussion between the two of you after you tell us a little bit about what you were doing with your new therapy for treating C. diff. If it's doubling, you're going to be a very popular individual amongst her patients.
Certainly, it sounds very scary. So as far as my research is concerned, we were looking at basically literature, looking at vancomycin dosing for treatment of CDI. We found that there is really no study suggesting that higher dosing of vancomycin orally is any better than the lower dose of 125 milligram given 4 times a day. However, in our own institution before 2008, we have a lot of prescribers that request oral vancomycin at the higher dosing regimen, anywhere from 250 milligram to 500 milligram given 4 times a day. But then since 2008, with the establishment of our institution antimicrobial stewardship program, we educated providers to use the lower dosing regimen based on information in the literature. We also established an institution guideline for treatment of CDI, recommending the use of the lower dosing regimen for severe infections. So because of this change in prescribing practice, we wish to look at clinical outcome, whether changing this dosing recommendation has any implication on clinical outcome. So we did a retrospective chart review from 2006 to 2010. What we found is that there is really no difference in terms of clinical outcome between the lower dosing regimen of 125 milligram given 4 times a day and the higher dosing regimen, 250 milligram given 4 times a day or higher. And what we found is we use less drug and certainly there is cost saving associated with using the lower dosing regimen.
Well, plus, you're lowering the antibiotic selective pressure in your respective units by cutting that dose. And, you know, we have experts here on antibiotic stewardship in you two, and maybe you'd like to speculate on how this study, Dr. Chung's, is really reflecting on the importance of antibiotic stewardship. Kelly, I'll go to you first, because as a pharmacist, this is one of those emerging issues that pharmacists, and especially hospital pharmacists, are really struggling with our prescribing colleagues, is the whole importance of antibiotic stewardship. Kelly?
Exactly, and you know, just making it specific to Clostridium difficile infections, antibiotic exposure is the primary risk factor for the development of these infections. And so the goal should be to limit antibiotic exposure as much as we can while still having good clinical outcomes among our patients. And so, you know, the goals of antimicrobial stewardship programs are to limit drug exposure. So the questions that are really asked are, is it the right drug for the patient? Is the organism susceptible to this drug? Is it the right dose? Are we optimizing pharmacokinetic, pharmacodynamic parameters, staying within therapeutic ranges, and also the right duration? I know we were talking earlier about, we say 10 to 14 days of therapy. Where does that come from? Is that even necessary? And so, pharmacists specifically can be very helpful in these programs. They're generally led by infectious disease physicians, but generally in collaboration with clinical pharmacists as well as the microbiology lab and infection control teams. So, overall, with Clostridium difficile infections, there are just more and more studies coming out all the time showing that antimicrobial stewardship programs are resulting in a reduction in these infections and other healthcare-associated infections in hospitals.
So, Dr. Chung, how did your prescribing colleagues react to your findings? Were they generally receptive towards cutting the dose? Were you an evangelist out there effectively preaching to the unconverted, or was it an easy fix for you?
Certainly, for the most part, it was well received. At least the guideline was well received by the prescribing colleagues. Certainly, in certain cases and certain prescribing clinicians, there's always challenges in trying to convince them to change to the lower dosing regimens.
Because if some is good, more is better.
Right, that's usually the rationale behind wanting to use the higher dose.
So this is the famous question you ask all graduate students: what's next? So in both your respective studies, what's on the horizon for next? You have these very exciting findings from both of your collective studies. So how do you move it to the next level to really lower the incidence or control this whole emerging epidemic of C. diff? Thoughts?
Yeah, so what these big epidemiological studies do is really shows the burden of infection. And so really the goal is to incentivize hospitals, clinicians, to put more effort towards preventative efforts. And so as we have these large studies and start doing more surveillance, national surveillance for Clostridium difficile infection, and we're starting to have mandatory public reporting of these infections, I think we'll start seeing a reduction, and hospitals and administrators will start pushing for more preventative efforts and infectious control teams and things like that.
So before we go to Dr. Chung to get his perspective, we have another question.
Yeah, Michael Smith, MedPage again. This is actually for Dr. Chung, so we'll go right
good.
to Dr. Chung perfectly. Dr. Chung, a couple of questions actually about this. First of all, I don't know what the MICs are for vancomycin and C. diff, but did you measure resistance arising from the lower dose?
We did not specifically try to measure resistance because, as you know, it is very unusual, except in the clinical research setting, to perform MIC testing for Clostridium difficile. And to answer the first part of your question, what has been reported in the literature in terms of MIC for C. diff range anywhere from 1 to 4 microgram per ml, and that's the MIC 90. And then the absolute range of MIC range anywhere from 0.06 to 8 microgram per ml for all the C. diff isolate that has been reported. And some from more recent study comparing vancomycin to the new agent fidaxomicin.
How would that relate to 125 milligrams 4 times a day?
Sure. So the 125 milligram dosing of vancomycin gets you about anywhere from 50 microgram to 2,000 microgram per ml of vancomycin in the feces. So that is usually used as a surrogate for intracolonic concentration. So if you do the math, the vancomycin concentration is about at least 10 times the MIC 90 of most of the C. diff strain.
And this is at the lower dose?
Right, at the lower dose of 125 milligrams 4 times a day.
So this really his question really drives home the fact that some is good and more is bad, because you don't need that extra dose, and it's adding to the selection pressure that's in the unit itself, because if you're using so much more, you're effectively increasing the antibiotic pressure on that unit. So that's a really profound question that you've asked. Thank you.
And, a follow-up question is, obviously vancomycin has, like any drug, has adverse effects. Did you measure the changes in drug-related adverse events between the two cohorts, those who had the lower dose and those who had higher dosing?
Right. So it's certainly possible that oral vancomycin, although it's not really systemically absorbed, there has been speculation that it may increase colonization of vancomycin-resistant enterococci in the GI tract. However, we did not specifically look at, for example, this type of adverse outcome. Our study primarily looked at whether there is a difference in the clinical outcome of CDI treatment with these dosing regimens.
So that would be, if you are fortunate to be in a hospital that screens patients on discharge for VRE, you could, of course, do that combined study. Look at CDI rates with your vancomycin regime, in addition to looking at the emergence of VRE colonization in that patient cohort.
Right, certainly.
So that's what's next for you. And now we're going to actually do that. What's next for you?
Sure. You know, the study was a nice study in my mind, but there are several questions. Well, at least there's one big question that we weren't able to answer. Current recommendation for treatment of severe complicated CDI, those patients that are hypotensive or have ileus or treated in the ICU, the recommended doses for vancomycin is actually 500 milligrams every 6 hours. Because of the fact that our study didn't have a lot of those patients, we weren't able to determine whether the different dosing regimens are different for that particular subset of patient. So perhaps we would do may not be a randomized controlled trial, but perhaps a observational trial to see if there's a difference in outcome with using a higher dose for this particular subset of patients.
And then you could look at the patients by fractionating by Apache score from the ICU to effectively look at severity of disease in the patient to know whether they're inoculating themselves from the inside out.
Certainly.
Yes. We have another question from the audience.
Lynn Peterson with Trends in Medicine. So I'm wondering if these patients, you looked at recurrence. Did they get recurrence?
We did not. Okay.
Kelly?
Yeah, so the National Hospital Discharge Surveys just look at discharges in general. So unfortunately, when you look at a discharge, you're not sure if it was a first episode or a recurrent. So we can't make any generalizations or capture the incidence of recurrent CDI.
The problem with de-identified data.
Exactly, and they don't capture 30-day readmissions or recurrences or anything like that.
And Dr. Chung?
So in our study, we have about 30% of patients that had a history of CDI, although we didn't really quantify the time period of when they have a previous episode of CDI. So we didn't really specifically look at recurrence at the beginning of the study. What we did look at is readmission due to CDI related causes such as diarrhea, abdominal pain, and we found that I want to say a very low number of patients got readmitted for CDI within 30 days after primary initial treatment.
Was there a difference between dose?
There was no difference.
No difference in dose. There are a number of drugs in development for C. diff, and Vanco is cheap. So as you look at these new drugs, what is your thinking about where they'll fit?
Ooh, that's a really provocative question. Take it. It's your time to speculate.
Okay, so speculating based on what my observation is from my data set. My feeling is that if patients were going to do poorly on vancomycin, they will do poorly on whatever dose you give them. So if the patient do not respond to a high dose of vancomycin, perhaps it's time to go to a different agent.
So then there's room for new antimicrobials for treating C. diff, but it's going to have to likely be different than the target that Vanc's going after, or do you think it can be the same target?
Certainly, if a different target is can be discovered, then certainly that would be a better option for treatment of CDI that failed vancomycin, which is a cell wall active agent. For example, I guess the newest example would be fidaxomicin, which act by a different mechanism.
Right, and you really have to look at the cost effectiveness. The cost of a hospitalization for C. diff is about $25,000. So, if you can have a drug like fidaxomicin that prevents recurrences better than vancomycin does, and you see that, that
the cost-benefit ratio.
Yeah, the cost-benefit ratio. So, as these new antibiotics are coming out, that's certainly going to be something that's going to be studied. I mean, there's usually cost-effectiveness analysis that come out pretty quickly after the effectiveness analyses are done.
And again, if you have a question, feel free to ask us via the Twitter hashtag ICAAC, and we'll be happy to take your questions. So, I guess my question then is the Vanc good because you get such a high concentration in the colon where the C. diff is effectively living? Is that why it's working at such an effective low dose, if you will? It's because it's bleeding into the colon when you're administering it?
Right, so that is really the rationale for using the low dose because of the high concentration, which is far greater than the MIC of most C. diff isolates. And using the higher dosing regimen certainly would give you a better concentration to MIC ratio. But the fact is, you don't really need that much higher of a concentration to kill most isolates of C. diff.
So is there one question that you two would like to ask each other?
I mean, I guess my question, it goes back to the question previously, looking at recurrences, and especially looking at second, third, fourth recurrences. Right now, there's just not a lot of data out there on the effectiveness of different antimicrobial regimens. So it's more just a comment. I think it'll be interesting to keep looking at different regimens and Vanc at different doses compared to different antibiotics, just to see what the best antimicrobial regimens are for recurrence.
Right. Certainly, there's currently not a whole lot of data for patients with multiple episodes of CDI. Clinicians have used a number of agents to treat these patients, and I'm not so sure that any one of those agents or combination of agents have any good success. Certainly, if we could look at that particular subset of patients, that would be very important in terms of curing those patients for this particular infection.
Yeah, one of the things that I wondered, and I know neither of your studies can answer this question, is looking at it from the perspective of whether or not it was what toxin was being produced by the organism and whether it was the double whammy bug that was making both toxins and the effectiveness associated with it. Unfortunately, those data aren't available in the discharge summary.
Correct, right.
And so, if I was thinking of what's next, that's what I would like to know, but how do you get those data? You almost have to expand your search and hope that they're going to ID the microbe and ID the toxin.
Exactly, and so you'd have to have a diagnostic test that can capture toxins A and B too. And another thing too is the changing molecular epidemiology of Clostridium difficile infections. We've seen the emergence of hypervirulent strains in the previous decade or so, and so looking to see if certain regimens are more effective against those too. So there's a lot of questions that are still unanswered about C. diff.
One of the things that I'm curious about now is we learn from our friend MRSA that it started out in the hospital and then moved to the community. And now there has been much talk about C. diff moving again from the hospital to community-acquired C. diff. So I'd just like to gauge your thoughts and perspectives. You two are the experts on C. diff, and what are your thinking on C. diff moving into the community and community-acquired CDI?
Sure. So, there's been increasing reports of C. diff in the community in recent years, and a recent study showed about half of all CDI episodes first occur in the outpatient setting. And so, and this makes sense. I mean, there is so much antibiotic use in the outpatient setting. Certainly, C. diff can be a problem. And so, right now, it's still kind of hard to track these patients because there's not often follow-up, or the patient ends up getting hospitalized. There's a very small subset of patients, about 10% or so, that develop a community-acquired CDI and never get hospitalized. So I think that's another area where we still need a lot more research in, and especially comparing therapies as well.
Another question from the audience.
Hi, Jeff Fox, Microbe. In your trends data,
Yes.
you said that you saw some leveling off.
Yes.
That was a gross overall trend. Can you drill down into that data to see whether that's regional or whether there's any specificity within that trend?
Absolutely. So the National Hospital Discharge Surveys do collect data on geographic region, and it's the geographic regions defined by the U.S. Census Bureau. And so absolutely, you can look at geographic variations. I haven't looked specifically at that subset, from 2008 to 2010, but overall, if you look at the incidence of CDI, the Northeast actually has quite a bit higher incidence, almost double the incidence compared to the lowest region, which is the West.
Is that a confounding effect of reporting and discharge summaries, or?
No, I went and took the total number of CDI discharges over the total number of hospitalizations for that region. Oh. So I'm thinking it's more a function of just antibiotic prescribing or distribution of comorbid illness. There's a lot of things that we can't capture in this in these databases that could probably be accounting for that.
It could be something as simple as the age of the hospital. The hospitals in the Northeast are much older than those out west because the population demographic has moved from the Northeast to the West because of retirement, and they're all new hospitals.
Yeah, that's a great point.
It's the age of the hospital or the age of the patients in the hospital?
The patients in the hospital.
No, I actually think it could be the age of the hospital because C. diff, is in the woodwork, so
That's
to
true.
speak. And it also could be a function of the age of the hospital, age of the patients as well, having a greater number of, just the population mix.
Sure.
I have another question for Dr. Chung about the vancomycin failure rate in these patients. Regardless of the dosage, how many of the patients are failing treatment?
Based on the study, less than 5% of those patients failed vancomycin. Certainly, it depends on how you define failure. Sometimes a patient may not improve after 72 hours. And my study specifically looked at improvement at the 72-hour time point. So based on that, about 90% of patients had clinical improvement at that time point. So with that definition, you could say that perhaps 10% of them did not respond as fast compared to the rest of the 90%.
Well, looks like we have a question from the Twitterverse.
Well, it's not from the Twitterverse. It's actually a reporter friend of mine who is watching online emailed me a question for
Okay.
you. Terry Murray from the Medical Post Toronto has posted this question. Do you have any thoughts about the late-breaking British poster in which whole genome sequencing showed low C. diff transmission rates in a large hospital? Are you familiar with this? I can go on, there's more detail.
I am not.
We got to go see the late breaker.
Yeah. Apparently, only a sixth of C. diff cases could be attributed to ward contact with a symptomatic patient. A further 10% had a possible donor when spore contamination of wards was considered as a source. So are we wasting time and resources with current attempts to mitigate transmission that doesn't appear to be happening? What do you think the implications of this study might be?
I think it's a very provocative question, and it's one of those papers that you're asking, is it, being moved amongst contact, touch, or whether or not it's just literally falling into the patient from the environment. So it's one of those posters to go down and check out. Dr. Chung?
Yeah, certainly. I don't know too much about the poster.
That's the challenge with these late breakers is you get the abstracts like we're just like your reporter friend. We just got the abstracts and now we're busily working our way through the program. Another question from the audience.
Yeah, maybe Michael Smith, MedPage again. Dr. Daniels, at the beginning of this event, Dr. Schmidt asked for you to say why this is happening, your increase. Do you have any thoughts on why the rates have doubled in a decade?
Sure. So there could be several things that are contributing to the increase in CDI. For one, use of antibiotics. And it looks from some prior data that we are starting to reduce the overall use of antibiotics, especially in the outpatient setting, but with that has come an increase in broad spectrum antibiotic use. So if you look at some of the classes that are more associated with Clostridium difficile infection like fluoroquinolones, we've actually seen an increase in fluoroquinolone use. So definitely antibiotic exposure is one thing. Like I mentioned earlier, the changing molecular epidemiology. There's thought that some of the newer strains like ribotype 027 has greater transmissibility between patients, so that could increase incidence. Another thought that I had is advanced age is one of the biggest risk factors as well, and our population is aging. So we have a greater proportion of patients who are living longer and have comorbid illnesses, antibiotic exposure, frequent hospitalizations, and so that could be contributing to the increase as well.
It goes back to what Dr. Chung wants to do next of looking in the ICU population, and there, because we have the ability to have an Apache score, which is a measure of how ill the patient is. If you fractionate the data based on that, it may get to being able to answer definitively, is it the severity of illness in the patients? And of course you can control for all the demographics,
Sure.
age and antibiotic exposure and things along those lines, and even control for class of antibiotics that they're actually receiving.
Absolutely.
New work, job security, as
Exactly.
my good friend in the clinical laboratory would say. Are there any other questions? If not, I'd like to thank you for joining us today on ICAAC Live. And again, you can follow us at #ICAAC. And again, if you should have any questions, feel free to post them and we'll try to answer them. If not, thank you and we'll see you again.
Once you're in the BSL-4 space, the only way you can get out is to go through a chemical shock.
It's an unusual room, never seen anything like this. Anybody who has access to this facility first has to go through an R scan. So the HEPA filters filter the air coming out of the facility, and that will remove bacteria, viruses, anything that might constitute any kind of risk, right? Remember, this building is basically a second building inside the main building.